So while we're waiting, I think one of the super excitement about today's workshop is, of course, we're presenting our research outcome for the 12 months. But the other thing is, we are fortunate enough to have speakers from all sorts of backgrounds, right? So you already heard that, people from government sectors, people from media, people from, other groups, like even they are academia, they are working at different areas. They're working in geographical science. They are working in data visualization. And you just heard Chen Yang, we actually coming more from a software engineering background. But if you have to say who's the best speaker for this pandemic misinformation, I would say like Professor Catherine as our chair of pandemicology. Well, she will definitely be the best person to speak about everything for this, right? As you may already heard, our DVCR Professor Julie Owens mentioned this morning, Professor Catherine is our Deakin's face, to the government during the pandemic. Actually, I have to say I'm a big fan of Professor Catherine because I have the morning when I turn on the TV, because I think most of our children did that, while during the pandemic, I watch the news, hope there will be experts to give us the authentic, true information about what is going on. And I'm super excited when I see Professor Catherine on the TV because she is coming from Deakin. So it's really, really our honor to have a Professor Catherine with here today. I know she was trying a lot, great efforts trying to make personal here, but I know she's occupied by other commitment and she will have to heading to the airport 4 o'clock. So without further ado, the floor is yours, Professor Catherine.
Thank you so much for the invitation, and I'm sorry I couldn't join you for the rest of the day. I am in Sydney actually, so my return flight to Melbourne was delayed. I am getting feedback, so I don't know whether we've got sound on in the microphone on in the room.
We can hear you clearly.
We can.
Okay, it's just that I'm getting, no, that's better. That's good. That's gone now. Thank you. So look, I've put some slides together, which I think are a bit of a helicopter view of my experience of information, and particularly when information was misused. And sometimes that was deliberate and sometimes it was not. So let me pull up my presentation. Sorry, I'm just trying to... I've only got a single screen here, so I can't get it to... I'm still getting feedback as if there's a microphone on in the room. I'm not sure how to get the presentation up and share screen at the same time. Can someone just give me some advice here? Because usually I have 2 screens, so I'll go into the presentation so you can see it and share. And then I'll go into...
Yeah, it's coming. Yep.
Yeah. Okay, so if I do it this way, will that... Can you see the presentation now?
Yep, full screen and your image order. Awesome.
Perfect. All right, thank you. So I want to talk about the difference between disinformation and misinformation as I talk through today. And I'm sure you might well have had conversation about this. But this comes down to whether or not... I'm sorry, I'm getting this terrible feedback. Can the microphones be turned off in all the rooms so that I'm not hearing my own voice? Thank you. It's really hard sometimes to know what the motive is when wrong or wrongly interpreted information is shared. So I'm sorry, but it's just, there's a microphone that's on that's feeding the sound back to me in delay. And so I'm getting, that might be better. Anyway, I will go on. So that's what I want to talk about today, because we don't always know whether it's good or bad intent, but it can have a terrible impact in a pandemic. So that's what my focus is, how information can be used well and why we rely on it so much, communication and evidence-based communication, both with government and evidence-based policy, but also importantly with community. So if you think about public health messaging in the pandemic setting, there are certain things that happen necessarily. You have uncertainty as soon as you have a new human pathogen and we're heading into a pandemic situation, you automatically are faced with uncertainty. And there's nothing more frightening, I would imagine, from the public point of view, when they can see that even the health departments don't know what's going on, at least initially. And that uncertainty can very readily breed fear. And you have to manage that, because otherwise you're introducing other health impacts as well. If you have inconsistency, if in the absence of really firm and strong evidence, people start doing things differently, then that can lead to confusion and mistrust. And if it's actually different states in your own country doing things differently that isn't about the nature of the state, but it's about the choices made in the absence of evidence, or experts are giving different advice, all of these things, even with the best intentions, can actually give a different signal to the community. So a population isn't in isolation. We're looking at what's happening in different parts of the world. We're looking at the consistency in the understanding of the evidence we do have. And I think that's something that we don't always do well, particularly in the early stages of a pandemic. In Australia, quite quickly, they formed what was called the National Cabinet to bring together the states and territories. And that was probably one of the most significant early interventions that was put in place, so that chief health officers from around the country, with their first ministers from each state, could sit in a room together, with the Australian government and actually talk some of these things through. And so at least initially we had quite good consistency. And I think that was really important to help bring the public along. But we also know that conspiracy theorists love pandemics. There was a real opportunity for people to step in and take advantage, particularly of that initial period of uncertainty. And there are also political agendas around this. We saw some premiers take a certain stance, and where they then surveyed a community and the community come back and say, oh, we felt safe because of that. Then you actually see that starting to perpetuate that particular stance. And so there can be a separation then between what the evidence might be telling you and what is deemed to be a good political choice or a good set of policies based on what the community are looking for as well. But alongside all of that, and partly because of that, there's this hunger for data. And so people just want more information, and that need has to be fed. They'll find the data if you don't present it to them. And in fact, that's what happened. A lot of data that might be available publicly normally, but is never accessed by the general public, was starting to be accessed. There was also lots of claims for freedom of information, under freedom of information, to access health department and other data, the vaccine company data from the trials and so on. As an epidemiologist, I think the thing that was starting to make me very concerned very early on is that these numbers were deceptively simple to people. It was case counts, so we need to know what's going on. It was a number of people dying, and we know that if you're a different age bracket, you have a different death risk, and so just give us the information. But they don't realise how, firstly, difficult it is to collate information, to clean it, but also the information itself was often incomplete or compounded. You might have the number of people in hospital, for example, but you didn't know if they were there for COVID or with COVID, or just screened, even they're in hospital at all, but they were screened as visitors and then counted amongst those hospital cases. But all of this is coming back to the main point, which I started with, which is how important communication is. It links policy to action, and that is how you achieve outbreak control. Engaged population is your intervention with this sort of communicable disease. And you have to really work on that, because if you get that wrong, that's when you'll get worse health outcomes. This was just a thread on Twitter that a reporter, quite a senior reporter with The Guardian, put together, talking extensively about women in leadership roles in COVID. But I was pleased that she was one who recognised the work we were all doing behind the scenes, who were doing this front-facing media, that we actually spent a lot of time with the media trying to help them understand the science, to encourage more reliable reporting. Because if they had a superficial understanding and were just going for the big quotes or the scary quotes, things could go wrong. But we actually invested a lot in trying to help the media themselves become competent communicators. So I'm just going to give you a few of the examples that we dealt with right from the start around misinformation or disinformation. There was a whole program around the PCR, polymerase chain reaction testing, that stemmed from some interviews of the now deceased person who helped invent the PCR method, talking about what it can do and what it can't do. And we all know the limitations of PCR testing. We've been using it in outbreaks since over 20 years. We used it in a pertussis outbreak. But there was this kind of general hiccup where people who were suspicious of government, particularly in the USA, started saying you can't use PCR tests and misquoting bits of this to say that it was all wrong, or PCR tests pick up a human gene, so everyone's going to be positive, so they're overstating the cases. There was true confusion between the death statistics, particularly early on, where people dying who were going to die anyway, but happened to have tested positive for COVID just before they passed away. Or were these people who died of COVID-19, the disease? So was it a SARS-CoV-2 infection that was incidental, or was it a death where COVID-19, the disease, was part of that death, the cause of death? And then the flip side, where people could sort of discount the data because they say it's not clear, therefore we can't rely on it, then they just say COVID-19 is just like the flu, and therefore we don't have to do anything. Some people just discounted that it was a problem because they thought it's only for the old and unwell, and we don't care about that. But of course, even if you didn't have any compassion for the elderly and the unwell, if your health system can't cope, everyone's impacted. So we'd spend a lot of time trying to explain to people why you had to think about this at a whole population level. And then we had those who thought that, in fact, if you were healthy yourself, you could beat anything, and natural immunity is best. Trust yourself, have an infection, get over it, you'll be immune, and that's going to be better than any vaccine. And of course, we know that infection after vaccination is a less traumatic, less likely to cause severe disease than infection before vaccination. And that was Australia's effort to try and get people vaccinated before we had the virus circulating in the community. And then, of course, we had hydrochloroquine and ivermectin, where people didn't have any evidence really supporting those drugs, but a few clinicians who thought they worked and put out, incomplete trials, or there were some small trials, started this whole movement globally where people were saying we need to put these drugs in place. They're working, they're cheap, it's just we're selling out to the vaccine companies if we don't do this. So these same people didn't want the vaccines because they claimed there wasn't enough evidence about vaccines, but in fact they wanted these drugs permitted or approved when there wasn't anywhere near the evidence that we had for vaccines. They wanted these instead. So it was all a bit ironic. And it's the conspiracists and the opportunists who take advantage of this. And one of the opportunists was a well-known figure in Australia, Pete Evans, who's a naturalist and so on, and a television personality. And his group put out this biocharger, had a much more complex name, I can't remember it now. It was only $80,000 Australian, but it would clear your house of COVID, they promised. So they actually, there was legal action taken about this, but having information coming through everywhere, including advertising and selling products, was really challenging for the government and for health people alike. And because some of it was disinformation, so some of it was very deliberate and very well organised, but some of it was just people looking at the data, hungry for data, and misreading it or misunderstanding it. And so, as I said, vaccines were one of the areas where we saw a lot of this going on. And it played out in different ways over the course of the vaccine development and rollout. Initially, it's too quick. We haven't spent the time we'd normally spend developing a vaccine. And rather than that being a good news story, people were anxious. There were elements of the vaccine trials where things that are normally done in series were done in parallel, where governments were actually collecting the data from a trial in real time, so that when the trial formally finished, they just had to add in the last bit of data. Usually they'd start their analysis then. So they did deliberately cut out time where they could and do that safely. Some countries overseas, from our perspective, actually also put through emergency approvals. We didn't in Australia because we were successfully holding the virus back until we had an approved vaccine. We'd waited for the full safety data and so on. But again, there was a lot of misinformation about what that looked like. And then, of course, all the stories began about how it would kill you, how the spike is toxic, how if you didn't die now, you would die in 10 years' time because something terrible would suddenly happen with these vaccines. How can we know they'll be safe in 10 years? And it is new technology, but we had never had a vaccine that, if they had a problem, it was going to be usually immediate, sometimes within weeks, but we hadn't seen anything else where we had a problem in 10 years' time. But then there were questions about fertility that was putting people off, particularly pregnant women. It's true the trials didn't include pregnant women, but as soon as they started rolling this out around the world, there was a women who didn't even realise they were pregnant came into the real world trial, the phase 4 trial, because they were vaccinated as healthcare workers and they were fine. And in fact, not only that, we discovered that women who weren't vaccinated and who were infected actually were more likely to have a preterm birth, and they themselves were more likely to have severe illness. But we had this counter information coming from the anti-vaxxers that was undermining that. So we had to put more work in trying to correct the wrong information rather than focusing on the real information, which was pregnant women are a priority group, and we really do need to make sure that they're aware of their risks around vaccination. And then there was the crazy stuff. This is sort of easier in a way because it was at a time where they said mRNA vaccines, you know, magnetised you, that you could hold a fork to your head and it would stick to you because you're magnetised, and those sorts of silly things. But the other thing was that your chance of passing the virus on, and the initial vaccines weren't tested for that. The trials were all about actually having a vaccine that would protect you from serious illness. But in fact, we discovered even if you had a breakthrough infection, which was less likely, you would have less viral load, you were less infectious to other people, you're infectious for a shorter period of time. So they actually did prevent transmission, but a lot of people just went back to the trial data and said they didn't. And so there was a lot of, again, unhelpful debate about that because it was a bonus, it was good news, but it was swamped by people saying, no, it doesn't. And then, of course, with the new variants coming along, the effectiveness did start to drop, and the protection we had also started to wane. And that was always one of the possibilities about this. But remembering the vaccines were all about preventing serious illness, they still did a remarkably good job of that. Just those bumper bonus, less transmission and less any infection risk wasn't as sustained over the new variants as we might have hoped. This is a classic example of the kind of misinformation, innocent, I think, misinformation, but sometimes then deliberately manipulated by people. So this is a complex diagram, but if you just looked on the left-hand side, you can see what we often heard reported, whether it was deaths or COVID, but you actually, quite late in the vaccine rollout, but you would get numbers where in fact more deaths were occurring in vaccinated people than unvaccinated people. And this is the base rate fallacy. It's just because the majority of the population is vaccinated. So you would expect more deaths to be in vaccinated. Certainly if they were the same rate of deaths, you would expect it to be comparable to the proportion who are vaccinated and not. But in fact, it's not. The vaccines actually protect you. And in terms of, so this is the same circle over here set against the population on the right-hand side, you know, you're catching a very small proportion of the vaccinated population, but it might be that, you know, half your unvaccinated population have actually died, even though they make up less of your deaths. So it took us a long time, and this was one example, not mine, but that we took from a Twitter site, but just where people kept trying to explain to people that you can't just look at the raw numbers and not take into account the very different proportions of people who are vaccinated. It's actually even more complicated than that, because the people who were vaccinated were at high risk of dying. They were preferentially the ones that would prioritise for vaccination early in the rollout and the ones who had highest vaccine uptake. And so if the people that are at a higher risk anyway are vaccinated and you still will see some breakthrough infections and deaths, then it's adds to the complicated picture. And so they might have a remarkably reduced risk of death, but it's not zero, and they will still be captured in these overall statistics. But that's why we have epidemiology. That's why you have to look at all the confounders and look at the big picture, look at the base rates. And the public just didn't get that. They just thought you could look at the deaths and make some pretty rash decisions about it. But even if you go back to the raw data, so this is the kinds of figures we're used to seeing all around the world. This is Victoria. Data from Victoria in 2020, the first wave, remarkably small, mainly imported cases, very little community transmission. We had an outbreak in May at the tail end of that where the virus found its way into meatworks, so we had a bit more community transmission. And we also did some big blitzes. And so we hadn't been testing the general community, even if you had symptoms, in March, April, because we didn't have enough testing. But before we fully opened up, we did a big blitz and found a few more cases, but not many. So the first wave was contained. We had a meatworks outbreak that settled down. But then in June, we had a double seeding event. 2 hotel quarantine sites had crossover where security staff at those sites became infected and unknowingly took the virus home. And that then set off the second wave in Victoria, which to that time was, of course, devastating compared to the first wave in terms of numbers. What is interesting, though, is, when I look at these data, I think that's not your infection rate. That's actually your recorded infection rate. And they can be very different things. And so if you were to, guesstimate how many infections you had, particularly early on, you're probably only testing a fraction of the cases. Later on, we did more active case follow-up. You're probably getting a better idea about how many true infections are out there. And you're testing people around any case. So you're less likely to miss even asymptomatic cases. But what is interesting to me is we didn't really learn from the first outbreak in the way we might have. And in fact, when we go back and at that time did some serology surveys, they're very, very broad confidence intervals, so we don't know exactly. But we know we missed a lot of infections. And if you look at New South Wales alone in late March and February, we probably missed 1,000 pneumonias that were pneumonia deaths, not counted as COVID, but we don't usually see that number. There were excess pneumonia deaths in February, March. So it suggests for every one of those, there could be another 1,000 infections in the community. So we did have, not 1,000, sorry, 100 infections. So we did have more infections. We don't know how many it was. Some have estimated it might have been about 60,000 Australia-wide. Probably not that high, but I would say definitely 10 to 20,000. And so we completely, missed the opportunity to say, well, if we did have that many and we actually assessed that and done some community surveys at the time, we could have then been more confident about what it would take to shut down that second wave. But also how we communicated to the community. And if you want people to stay on board because the outbreak is being well controlled, that's how you get adherence to your public health messages. So you want very clear information to the community saying, what we did in the first wave worked, we're now going to do it again. It will work again. But that didn't happen. And there were some experts saying the second wave was because the first wave didn't work, which actually wasn't true. And so you wound up with people then being more resistant to the next lockdown because they thought, well, it didn't work the first time. Why are we trying it again? Or why are we doing it even harder? Or we need to do it harder. And I'd argue that what worked the first time should have worked the second. And if everyone had known that was the case, things might have played out differently. This is some of the work I did with the media was really about data visualization and trying to help people understand some of the complexities of an outbreak. It's not the virus just randomly spreading in the community. If you have 100 cases, they're not just spread right across your state. They're in certain places in higher numbers. Certain people are at more risk. And this is a breakdown of the second wave in Victoria, where they looked at where the outbreaks were that actually contributed more than 10 cases in an outbreak to that overall wave. And the blue shading is our aged care sector. And that was involved very early. And compared to all the others, which were brought under control in the way you would expect it, in about 6 to 8 weeks, and that's what normally happens when lockdowns work, we kept getting the virus fed back into the community by aged care. And so by early September, most of the cases were either aged care residents, staff, or the household contacts of those workers, with very little infection outside of that. So we stayed in lockdown, and people that might have been the thing to do, but no one was told that was what was happening. They were told the virus was everywhere. But in fact, you could have been in lockdown and actually felt quite safe going to your supermarket for that short period of time you're allowed to, because in fact, there was very little virus in the community apart from aged care. So I do think some of the collateral damage from lockdowns could have been better managed if they had been looking at this data in this way and actually really analysing it and seeing how we could be quite targeted. And so using data to plan the way ahead. The same happens geographically. This is the Bay. It's the city of Melbourne, situated around the Bay, but it's in the north, the west and the southeast, where we have our lower socioeconomic status suburbs, where most of our casual workers in particular work, and we have large extended households, lots of people who have English as a second language, culturally diverse groups who often move across households on a daily basis to share food, lots of things going on that actually support transmission. So as an epidemiologist, that's where you'd expect to see the virus. And that's absolutely where the virus would first land and where we would have our greatest number of cases. If that had been communicated to the public in terms of risk and the need to protect these communities, that might have been different to having a community that was actually in lockdown. And people saw these groups, where the infection rates were still high, as being the problem, as if they were somehow contributing and keeping me locked in my house because they're not doing the right thing in their suburb. And it became very divisive. And even our chief health officer was referring to them as the usual suspects, which again isn't helpful. This is Omicron in 2022. Exactly the same areas were impacted, the west and the southeast. And again, if we'd got it right, we would have been really focused on those areas. If we could see a wave coming, which we did have advance warning, we knew it was happening in South Africa. That's where you would go in and work with the communities to try and protect the most vulnerable people and make sure that, you know, everyone who could be getting their booster dose, which really did help with the Omicron variant, of those who are most at risk were prioritised for that and supported so that there would be less impact. So again, going back to the second wave, this just shows the groups according to advantage or disadvantage. The least advantaged groups, this is actually flipped around the other way, sorry. The top groups are the least advantaged. And this is where the casual workers were at the hotel quarantine. They took the virus home to those really high mixing populations with casual workers, and they wound up having the biggest outbreak in the second wave. The rest of the population had low numbers. They're in lockdown before it took off. It was easy to keep it controlled, but it was these other suburbs that had much more work to do. Another important bit of data was the genomics, and that was used very early and very well to try and track what was happening in these outbreaks. We had, no, the images aren't blocking the screen, are they? You can see my full screen, hopefully. So this was looking at the first wave in Australia down the bottom left, and all the ochre coloured dots are the imported cases. So this was mainly from the travellers who we were testing. And occasionally it would get into the community. You see a cluster of cases in the aqua blue. Then we had the hotel, then we had the Meatworks outbreak, which is the transmission network one. So that was sort of trailed off that. It was some community cases got into this Meatworks and that took off, but that was contained. But the second wave you can see is network 2 and 3, where we had these two separate crossover events from hotel quarantine that got into the community. The first wave was characterised by these inbuilt, assumptions that it was all imported, but they were the only people we were testing. So we're in fact flying blind from an information point of view. That I was more worried then because we just couldn't see what was happening. So we did bring in that lockdown to eliminate community transmission, knowing it was there but not measuring it. But in fact, as I said, that should have reassured us that even when we had the second wave, those same interventions could work. Wave 2, as I said, about suppressing community transmission risk, particularly while we had these aged care outbreaks we couldn't stop. But eventually that became about COVID zero, and there was a real push to have zero tolerance. So these 37 cases had this particular variant. It was the first time we had seen this mutation, the N501Y mutation, that was later to appear in alpha and actually made it a much more infectious and difficult to deal with variant, the first of the kind of very much variants of concern. And that's the smaller outbreak. That only caused about 37 cases, and that was contained. It was the other one that had a foothold in these higher mixing suburbs that actually got away from us, and that's when the second wave started in this transmission network 2. So by the time we came to wave 3, this was Delta. So this was while we were trying to get the vaccine rolled out in Australia, and we had to deal with Delta. And we had an incursion in New South Wales, and it came in through a limousine driver who was taking flight crews and other international travellers around, got into the community and took off. And then it also spread to Victoria. So you can still see we started allowing people back into Australia. So the orange is your tourists. We had some clusters, you get a crossover from the border in a few cases. But then we had a short lockdown period because we started to see some cases when there was some infected people came across the border from New South Wales. So we went into lockdown and we never really cleared that outbreak. So unlike previously, when we'd gone for zero, this time we kept going. And it would have been important to talk to people about what the variants were, what we did right, what we did wrong, because you're trying to get people to understand what's going on and why they should be on board. You've had a 12-day lockdown, you come out for 9 days, and then you go back into lockdown, and that ended up lasting for months. And the sad thing was, even though we had this genomic data, it was always reported on a 2-weekly basis until this really important time where we saw the cluster and we'd had to go into lockdown. And that was the time they actually stopped reporting. And I do think this hunger for data, it would have helped people, even if it's not good news, but at least knowing what's going on rather than just shutting down information. So interpreting information is really quite critical. And we did a lot with modelling throughout the pandemic. I'm not going to go into this in detail, but we used it right at the start to try and see how much we had to reduce the curve, flatten the curve, as we say, in order to be able to get 100% of people who needed an ICU bed into ICU. And that's why we chose the levels we did without knowing everything, because we didn't know how the virus would behave in Australia. We were basing it on what we were learning from Wuhan and other parts of the world. But then we went on, and in Victoria particularly, in the second wave, trying to navigate our way out, as we had been in this very long lockdown, mainly, as I said, aged care outbreaks, and then trying to figure out how we could get out of that safely without opening up and then just going back to where we were. And so they were predicting, you know, where we'd be. In fact, our case numbers were even lower. We put more measures in place. We did get down to very, very low numbers and eventually shut down the outbreak. But the interesting thing was they would use this modelling to try and say, well, how many cases can we have where we open up and it doesn't kick up, or it will kick up, and what's acceptable? But it wasn't used well and it wasn't communicated well. And so the first models, they didn't even tell us what was modelled. The later ones, they were saying, oh, we can't open up at these numbers because there's this 41% chance, you know, we'll have a problem. But in fact, it was only 17% of simulations saw a rise above 100 cases. That's if they did get it down to 10 cases, but they decided to get down to 5 without looking at even the modelling data. And the point about this was, when I talked to the health department about it, I said, this is actually a good result. You know, if it's only 17%, and we wouldn't let it take off anyway, we'd start acting, and that would make that even less likely. I said, I was surprised you weren't more confident and to say we can do this. But the thing that struck me when I talked to them is they didn't realise that what was actually being modelled was opening up to the levels that were applied in other states at the time, New South Wales, which was essentially no lockdown. They weren't talking about going to the next step on the pathway, which was a very slow, eased way out, easing of the restrictions. They were actually talking about opening up completely. So in fact, not understanding the data or not understanding the models or not communicating them well to the public is a real problem, because there's really good work being done and everyone has good intentions, but it's just getting the most out of the data so that we're able to learn from this. By that stage, our numbers were too low and they'd stopped using modelling after that. We used it with the end of the Delta outbreak across states. This is New South Wales. They looked at hospitalisations again as that kind of ceiling that you could live with a certain number of cases if your hospitals could cope. They were quite close in predicting when the wave would peak for case numbers, but they were way out with hospitals. And this was repeated across different settings. And they were always so far out. Probably a good news story, because it was saying vaccines were working even better than the modellers had factored in. But we should then learn and modify our models and follow the actual data and get better at predicting. And again, this wasn't all of New South Wales. Those stars I represent are the whole of state population. This was just focusing on the 12 local government areas where most infections were, but not all. Probably maybe over half, but certainly not the whole population. So these numbers were still poor projections. And the result became very divisive. Instead of having everyone thinking the same way, we're all using the data in the same way and making policy decisions or policy changes based on data, it wound up dividing people. So people thought, this is crazy, lockdown's too restrictive and not working, or we can't come out of lockdown, we have to have 0 because we can't manage outbreaks. And so the information wasn't as clear for people as it might have been. So I'm just going to finish by saying a few things around what was missing. And analytic epidemiology is an opportunity that was missed here, and we kind of jumped straight to modelling, which we haven't used in quite the same way previously. or we used case series and very descriptive work, but we didn't actually do the kind of middle ground analysis, where we would do analytic studies looking at risk in the population, understanding how to manage risk, who are the most at-risk groups, the core groups that we could work with. And part of the reason for that was the data wasn't built into systems in a way you could readily analyse. So I do think this is one of the lessons from COVID, is if we have data that's entered in a way that you can actually start doing these analysis in real time and interpret the data and get it out there, we might be able to avoid some of the problems, both in terms of how health policy was developed or reviewed, but also importantly about how it was communicated to the population. And the more refined you are, the more up to date you are in understanding where the virus is and how it's behaving, the less blanket you have to be in your approach. You can actually start to finesse your response and cause less collateral damage, but have it as effective as it can possibly be in managing transition. And now one of the other things we're focused on, of course, is long COVID. And there's a lot going on in this space in terms of the kinds of symptoms people are seeing and this uncertainty about medium and long-term risk of other conditions once you've had an infection. But the challenge for us is, while they started quite a while ago collating some of this information, it might look different in Australia to other countries where we had more people have an infection after vaccination, which we think is protective, but we have long COVID in Australia, so we have to understand what our prevalence is and what we need to manage in terms of the recovery of those patients. And it's, whichever way you look at it, they're talking about quite high numbers, and with the number of infections, this is a significant problem around the world. But interestingly, and we've just put this to the inquiry into long COVID in Australia, we don't have case definitions that we apply nationally and internationally. And that may change as the science changes. But if you don't have a case definition, you can't pull together the information that we can then compare across countries, use in country, be consistent, and start to answer some of the important questions about the resources we need to put into this. So in conclusion, we did a lot in Australia to build new underlying information systems. Data entry format, we've still got work to do trying to get ready for real-time analysis. Our data doesn't connect across our states into the Australian national notifiable database. And then that creates differences across states that are more about data collection sometimes than about infection rates. And so it just creates more confusion, which again opens up opportunity for either people with poor intent or just confused by the data to get it to misinterpret it. So there's other things that we can do around building databases with the end users, the public health departments, getting it all built for purpose so that we can then work in a different way as we go ahead, but also reanalyze the data that was collected and come out of this with a much better understanding than we could have had at the time about how viruses behave, what our modern population movements are like, and how we can both respond to and prevent pandemics. In Australia, we've just had a report come out, an independent review called Fault Lines, so it's worth a look if people are interested. But they made a couple of key observations. One was to literally modernise how governments use data and to think about that as a really important component, and to make sure we have the legal acts in place that allow appropriate use of data in these emergency settings so that we're flying less blind. And also, and I was very pleased to see this emphasis on real-time evaluation. That's been one of my big calls all the way through. If you're not evaluating the interventions that you have in place, you either don't know when to introduce them or stop them or refine them. And so it is a massive impact on the public when you're going to any of these restrictions on movement and on business and on their own financial situation. And so again, the data behind evaluation has to be built into the way we think about these things. That's what will give us consistency across states. That will allow us to finesse or refine or get that nuance in our response, be fleet or foot, be able to do it very quickly, and therefore have really effective communication with the public who are the intervention. And that promise of evaluation, that cycling so that you're constantly getting wiser and smarter and more effective as you use data in the format, in the process of the outbreak control. And I think that's true epic intelligence, and that's the legacy we'd really like to see coming out of this. If we get it right and we can learn from the control measures we have in place, we're in a much better situation when it comes to prevention and making sure we've got people on board with the information they need to do that work. So I'll stop there. So happy to answer questions if anyone had any questions. I know I ran through a lot. Hope I wasn't too fast.
Did you? Sorry, can you hear me?
Got you, yes.
You can hear me? Yeah. So my first question, have you ever been tested positive?
I haven't.
Haven't. Well, so what's your secret? Is that something you haven't shared to the public yet?
I work 14-hour days. That helps.
Right.
But you know, I have been obviously at work and at meetings and at Deakin downtown. I have been on planes. I do still wear a mask when I'm around other people, particularly on planes. Although it's interesting because I flew back from overseas very end of October 2019 via Dubai, and I landed, and within 24 hours I had a terrible pneumonia actually coming on, which I'd never had before in my life. And other people, my partner also caught the same thing, and we actually had very much the symptoms of COVID, and we'll never know whether that might have been one of the early cases circulating, you know, early November, late October. And but even if it's not, it certainly made me empathetic to people who had COVID, because I knew how terrible it could be to have, you know, be perfectly well. I was just actually remarking to someone what a great trip back, and I felt fantastic. And then, you know, within 24 hours, I was down with pneumonia. So yeah, I may not have had COVID, but I know what it is to get a nasty infectious disease that can debilitate you, and it made me very empathetic.
Thank you. I think I actually ask a question because I think recently Australian government or Victoria has announced that we are no longer reporting. We're required to reporting positive cases. I just wondering now, why is it now? Because we can see our friends in Indonesia. I mean, they're still wearing the masks in their rooms. So why do you think this is a good time for Australia or Victoria to lift the ban?
Well, in Australia, we've relied on home testing more and more. So some people still will get the PCR testing if they're very unwell, for example, and might need antivirals, or they're at high risk of serious disease. And so the way our home testing was working, though, it was self-testing and then self-report. You had 2 layers where people had to think to do it or agree to do it. And they wouldn't actually do it as often now as they would in the past. If you look at Victoria and New South Wales, that have had the outbreaks for the longest, because they had Delta in 2021, if you look at the rates in BA1 wave at the start of this year, and you look at hospitalisations, which are actually a good read of what's happening in the background population. We didn't have quite so many people in hospital for COVID, but it gave you a read of background rates because they were screening people. And if you look at case rates, they're up here for BA1 and they're down here for BA5. But if you look at hospitalisations, they're kind of the same. So it just shows us that we know we never have all case capture, but when the risk is dropping and the risk of serious illness is dropping, if people stop testing at the same rate, you're capturing less cases. And so our surveillance systems rarely rely on us capturing every case. We just want to capture them in a consistent enough way that we can read those trends and know whether the virus is on the increase or not, or what variants are circulating, or if we're seeing more people in hospital with COVID, is it because infection rates are going up or the virus is causing more severe disease? That's how you use surveillance. You do not need to see every case. And in fact, when people start to test more because they're getting worried, or they test less because they're not getting worried, it creates effects. It gives you this either amplification effect or a false decline in cases just because testing patterns are changing. So unless you're going to be very rigorous and not only say you must test, but follow that through and enforce that so it's very consistent, then you're much better off long term coming up with something that looks like other infectious disease monitoring systems, which is more based on serious illness we use sewage water in Australia, we use sewage water. That gives you a bit of an indication, but when it rains a lot, that dilutes it. So you don't know whether you've got less virus in the community or just more rain. So there's nothing perfect, but you just get a few data points that are going to be consistent, as consistent as they can be, and then you use them together to try and really keep a finger on what's going on in the community without trying to capture every case.
Great, thank you very much. Do we have any questions for Professor Catherine from the audience? Yeah, Jesse.
Hi, thank you, Catherine. I have one question. I think you also know Melbourne has experienced the longest lockdown. And so my question is, when the government makes the policy like the period of lockdown or so how many days about the lockdown? So is there data or model to support this kind of decision, or they just consider the pressure in the hospital and then they have to make the certain days for lockdown? Thank you.
That is a very excellent question, and I actually had a slide I took out in the end because I had too many slides, but I'd say that going into lockdown is really hard. Coming out of lockdown is excruciating, as we would say, because you've put all that work in, you don't want to come out too soon. And I do think we need really good data, really good evidence to inform that decision, the policy change, the timing of either lifting lockdown or easing out of it at the very least. And that image I showed you, which had all the different components to the outbreaks, you could see that you theoretically, you could approach that two ways. One is you say, well, we don't need the whole population in lockdown, but the families, the households of people who work in aged care, they should stay in lockdown. So you might have done that and had reasonable success. Or you would say, we're just going to put everything into closing down these outbreaks in aged care and really invest in that, and we can end lockdown sooner. But what happened in the end is we'd have what they call mystery cases. And if you had a case you didn't know how that linked into other known cases, they'd worry. They'd say, well, maybe there's one person in the chain missing, or maybe there's thousands and there's a whole lot of infection we can't see. And so it was actually a lack of confidence because they'd asked people to do so much. They were so tentative about coming out, but at the same time, didn't really know how to read the data or to be very active in their surveillance. That's when you step up active surveillance. That's when you really do work hard to understand what these mystery cases are telling you about risk in your population. Because what happened, we had in Victoria at the end of that long lockdown, 6 weeks, 2 weeks where we had less than 10 cases a day in a state of 6.5 million people. So at the most we had 9 cases in any one day. And for the last 4 weeks, the rule was they had to see 0 cases in that whole time. And the consequence was when we went into lockdown again, we had some circuit breakers, but we went into a long lockdown with Delta. It didn't work as well. They didn't have the compliance anymore. So I do think you need to bear in mind that these are not finite, they are finite resources. You can't just keep turning them on and off. The public get exhausted by it, particularly if they're not quite sure why it's there. So that modelling I showed you was actually trying to figure out how to come out of that longest lockdown, that second wave. But in fact, the modelling wasn't very good in the sense of they were modelling what it was like to open up completely, not are we safe and is it ready to go on the next path of this easing, which they'd already developed the plan, but they didn't model the plan. They modelled opening up completely. And when they said, oh no, that's too scary, they just made the plan even tighter, not using it to inform. So I think that's what we've learned is the power of information to make the right decisions. And in hindsight, I'm not sure anyone could defend that 6-week period with only single-digit cases a day in a state of 6.5 million. But the question about how we go ahead is exactly as you said. What then do we need to do to say we can call it now? We don't have to wait until hindsight tells us we left it too late. And I think that's what we need to get out of that data analysis that we do in retrospect, because we didn't have the data in the format to do it that way at the right time. Sorry, that was a long answer, but it's a really important question.
Great. Do you have any questions from UGM side?
So I have one question, I think. It's quite interesting presentation from Prof. Catherine, but currently in Indonesia, we have also the number of cases increasing in COVID-19. So my question is about what the next agenda that can, because in your slide, you see that effective communication link policy to action to outbreak control. What the next agenda to communicate the result or the model or something like that that can link to the policy to action to outbreak control. Thank you, Prof. Catherine.
Thank you. And again, an excellent question as we learn from this and go ahead. At the moment, I think what we need to be doing is really turning things around in Australia. It was a lot to keep that lockdown going for a long time, both in 2020 and 21 with Delta. There was a lot of emphasis on the fear of this virus and the fact, we had to go to these incredible extremes to contain it. But also there was genuine concern as more people became aware of someone who might be very unwell with it, and we saw those deaths rising. And that was the biggest concern, the reality that we had to go through in 2021 to see the number of people that still died, despite all those efforts we put in place to be vaccinated early and for that to work. So I think it's about communicating risk in a different way, rather than saying these are the number of cases. My big push at the moment is to say, can we express it in a way for the general population so they know what their risk of exposure is? So if you say to some young active person who's actually probably more likely to have an infection than an older one, but if you say, there's 56 infections in your local community, it sort of doesn't mean a lot. But if you say to someone, with the infection rate at the moment, you only have to meet 20 people before you've probably met someone who's out and about while they're infectious because they haven't yet got symptoms or they're not one of those people who tests, to give them an idea about risk. So I do think we have to move from general kind of approaches to everyone must do this and it's kind of a blanket approach to now saying, how can we present information to the community so it drives their behaviour? So they are helping us to stave off outbreaks because they know when to step up wearing masks. They know when to think about distancing again. They know when to not have people over to their house. And if we can start to get people moderating behaviour, the majority, not all, never all will do it here in Australia, because you're giving them good information for them to be in control of that, then I think that's when you start to move something that's long-term, that's sustainable, and that actually helps us manage other diseases as well. It becomes just a more educated population to turn what we've learnt from COVID into something that helps people manage individual risk in a way that gives us that population level control in a different way. So it's less top-down, more the top-down now is about really good interpreted information. And then it's, people are engaged in a different way, because I think the days of rules in Australia just aren't going to keep working. People were just burnt out, and you couldn't just start telling them again. I think we have to do it differently to help bring safe behaviours up again a notch if we need to, as those numbers start to rise, like you're seeing in Indonesia.
Okay, thank you, Prof. Catherine. It's very clear.
Thank you.
I'm conscious of time. As mentioned, that Catherine will catch the flight and leave the hotel to 5 o'clock. Oh, so 4 o'clock. So I might have just one last question for Catherine from the audience. Do you have? Okay, I might just have a comment, Catherine. I think, because your presentation actually covers a lot of data, which it can kind of help us to think back through from the few waves that we have all experiences. Actually, before your talk today, I didn't know that you guys as a epidemiologist actually use so much data for your work. Because I was thinking because most of the audience sitting here today, we're claiming ourselves as data scientists, machine learning, and we do a lot of research in data. But I think the big problem is, we learn a lot of data. Even some of those data from, WHO, from others, is medical data that we connected, but we are not the domain experts, right? We try to read the list, but sometimes we may jump to, totally different kind of, I guess, conclusions, which may somehow, as you said, like with all the best kind of intention, but may generate some kind of misinformation, right? That's a problem. So I think, even our 12 months kind of project has concluded as we will continue research in direction. And one of the most important thing is we'll try to have this kind of a connection with you guys as a domain experts who help us to kind of like to help really makes our model expandable. And I think that's the most important thing for this type of project, because we are coming from all good kind of intention to help with, generate more kind of authentic information, help people to debunking those misinformation. But I think one of our audience mentioned during the launch is like, well, if you don't have this kind of a human intelligence or human experts in the loop, you might end up like people actually misuse your tool, because they may use your tool, come up with some kind of facts that is not true, and you say like, well, this is how the big data tell us the model is actually trained to use all the data is more than the knowledge of one single expert, right? Things like that. So I think what probably we'll do conscious of time today. So hopefully, while you're back to Melbourne, Jianxing and I will hopefully to pay a visit to your office. I will take them there, and we'll see like how actually we can collaborate with you and for our upcoming projects. Okay.
Thank you.
Thank you very much.
I think it's all about collaboration, isn't it? Bringing all the expertise, including the data expertise. Absolutely. Thank you very much.
Okay. Thank you very much, Catherine. I'll see you soon. All right. I think we still have a bit of a time before we conclude today's session. So I would like to open the floor to everyone. So if you have any questions for those speakers who are still online, and also from me and Jianxing to answer any question relevant to the project, feel free to ask any questions. Or comments, or just sharing, did you learn anything today? You feel like it's interesting topics? Yeah, I will. Okay.
I'm not sure Siqing Wan is still online. So I actually have a question for Siqing Wan, because we don't have time to do that before. So yeah, as I can see that she was doing a binary classification using an NLP, but from my perspective, like it's just a binary classification, but there are a lot of people, they actually trying to be sarcastic when they, tweet or, do some like post on Facebook. So for example, like a couple of days ago, the Australian government just announced that the pandemic is over. So there are a lot of people say that, oh, I'm so happy that the Australian government ignored the importance of the COVID, right? But it's positive or negative, sorry. So they say they're happy, but it's actually sarcastic. So how can they do with that? Because, human beings are really complicated. So sometimes we see something in opposite way. So how can we deal with that? Some people can even, as Siqing Wan's title, people are censors, but sometimes we cannot even sense that, the sarcasm. So yeah, I'm wondering how will NLP deal with that? Yeah, that's my question.
Yeah, I know Sis is not here. Probably Jianxing, you want to put some comments?
Yeah, I can share something. Yeah, because Siqing is not online. Yeah, I think your question is mostly like NLP is a technique, but the people, the mind and the thinking is very complex. So how can we use the simple technology to deal with the complex human being issue? Is that your question? Yeah, I think from today's event, you can fully understand, like from several keynote speakers, and one important concept, as they mentioned, communication. and understanding. So I think we introduced our project, we just by using some NLP sentiment analysis or some IT technology to analyze the data, to fully to maybe deeply understand the people's mind and their opinion, and then we can group them into some topic modeling and visualize them out. Or maybe Xiao Huang also visualize some data visualization results. You can fully understand, okay, for example, giving one event or one virus, and you can understand the spatial distribution of the virus. And then, of course, maybe some person or individual person, they may be narrative or open. So it's actually very difficult to say, this technology definitely can solve all the issue for this person. I think communication and understanding and show some evidence about the decision that can help people. Yeah, this is my understanding. Yeah.
If there are any other questions?
Yes, Sam.
Yeah.
Yeah, so just a little bit question about some technical thing in COVID dashboards, COVID-19 dashboards. But I see that we mentioned about how we connect the data from the social network. But yeah, I just want to ask how we connect the information from the social network. And yeah. And regarding on that one, I also want to know that for example, like we show the data in the COVID dashboard. So how do we update it? For example, every day the data is updated. The data tomorrow is different with the data showing today. Yeah, so just wonder that how we do that.
I think Chen Yang has already left, but yeah, so I think you can visit the website. I think generally, like, you know, you can easily embed, you know, some of the Twitter accounts that you selected on your website. So those website has been, you know, updated, you know, frequently. And if you're talking about all this data, right, there's a few ways they can do that. One, of course, like if you just crowding the data from like the, you know, for example, like a WHO, you know, official website. That's the data that you can show on your website, right? But I know there are some other people that try to cross-validate because, you know, sometimes the data sources are different. They will try to, you know, get the data from all sorts of different data sources and then try to validate to each other. And then they will probably publish the data that they feel like this is most accurate on their website. Right, so it depends on how they do it. But I'm saying, you know, I know that you guys might have some questions for the keynote speakers today. So what we're going to do is we have already recorded today's workshop. So later we'll upload to our YouTube channel and also our project website. We'll also ask their permission for sharing their slides on our website. So if they give us the permission, we'll share their slides as well. So you will see their contact details. So if you have any questions relevant to the, you know, the invite speakers projects, feel free to, you know, send an email to them. Okay, thank you. Okay, I think we are exactly on time. So Helia, yes, from your side, is there any questions or like if you want to say something to conclude?
No, I don't think so because it's a Friday praying, so most of the students go to pray. But
Yeah.
no, I don't think so. We have.
Yeah. Okay. Great. Okay, thanks, Kitty. Okay, let me, on behalf of the organizing committee for this workshop, of course, the team for the Study Melbourne Research Project, I would like to thanks for everyone for coming to today, especially our invited speakers who join us either online or physically at UGM site. I just want to conclude today, as I mentioned many times, so this is just the end of a beginning for those research direction and our joint research on COVID-19 fake news detection and intervention. I'm pretty sure Hillier will agree with me. This is the second one, but will not be the last one. So we're looking forward to have a multiple, I guess, like versions of the joint research workshop in the future. Probably we can also consider to extend this to an international workshop if we do deem that will be appropriate things for us to do. Okay, thank you very much for coming today. I hope you enjoy the rest of the day. Thank you.